everyone, it's Tammy Sherrill, and this narrated PowerPoint is going to focus on other types of quantitative research than the randomized controlled trial or clinical trial, and also going to talk a little bit more about data collection, data measurement, data analysis, those types of things. So let's look at the objectives. Number one knows that quantitative research is conducted in three different sort of fashions: experimental design, quasi-experimental, and non-experimental forms. And you should be able to differentiate between these three and be able to identify each of these research designs in published research, and that you're able to differentiate and identify four basic research designs: retrospective, prospective, cross-sectional, and longitudinal. Continuing with objectives, you should know that much of healthcare practice is based on correlations rather than demonstrated cause and effect relationships. So you want to be able to articulate how correlation differs from causation, identify correlation from causation in published research, and that you're able to articulate the impact of this difference, the impact of it on our understanding and interpretation of the research findings and application to practice. And then thirdly, we're going to dive into sampling this class as well, and so it's important that you know the effect that sampling methods and sample size can have on external validity or the generalizability of the research findings. So you want to be able to articulate the difference between populations and samples, articulate the difference between probability and non-probability sampling, and that you're able to describe common sampling techniques used in quant research. Okay, so let's get started. So by the end of today's lecture and class content, you will have the concepts and the critical questions needed to complete a quantitative appraisal. So your job is to move the learning from theory into practice. So the question, are you able to independently answer the appraisal question? Were the methods used in this study good enough that I can be confident in the findings? Is the research trustworthy? So this is a review from a previous class where we looked at the three types of quantitative research. So starting on the right side with the two types that test and intervention. And last week we looked at experimental design, classic experiment, randomized controlled trial, sometimes called the clinical trial. Today we're going to touch on quasi-experimental design. And remember, this is also testing and intervention, but usually lacks one or both of a randomized sample or a comparison group. And then the third type is descriptive or correlational research. So this is not experimental, we're not testing an intervention. It might be something very, very simple as a survey that does produce mathematical numbers and statistics, frequencies, percentages, etc. But we're not testing anything. But there also is a type of non-experimental research where they look for correlations between the independent variable and the dependent variable. So we're not manipulating the independent variable. We're just looking to see if there is a relationship. We just observe what's already happening in nature. So there was an interesting study done with parents whose children were admitted to hospital, and they looked at the congruency between what parents said they wanted to be involved in and what they were actually involved in. So we didn't test an intervention, we didn't allow some parents to be involved and some parents not. We just observed what was happening, and the results of the study showed that parents aren't doing what they really want to do. And so then the question is, how can we as nurses and a healthcare team involve parents more in the care of their child? So once again, a review slide just to get us thinking, quasi-experimental. What you'll see is the manipulation of the independent variable, but missing one or both of a randomized sample or control group, and then the non-experimental design lacking manipulation of the independent variable. Okay, we're going to look at measurement in data collection. And this is really important when specifically we are measuring abstract concepts. So let's start by looking on the left-hand side around reliability. So reliability is the degree of consistency or dependability with which an instrument measures the attribute it is intended to measure. So is the measurement tool, is it repeatable? Is it stable over time? Is it dependable? Is it consistent? And so the question we ask ourselves is, are the measures in this study reliable? And another question we ask is, does the researcher report on the reliability of tools or instruments they use to measure the variables? That's really important from an appraisal perspective. On the right-hand side, we have validity. So this is the degree to which an instrument measures what it is intended to measure. So, more straightforward when we're looking at measuring blood pressure, heart rate, blood glucose, O2 saturation, etc. But a lot of times in research, we use scales to measure these abstract concepts like hopelessness, depression, stress, anxiety. So we want to make sure that the scale we're using to measure this measures what it is intended to measure. Is it measuring hopelessness, or could there be an overlap with other concepts like depression? So are the measures valid and accurate? And does the researcher report on the validity of the tools or instruments they use to measure? Okay, so let's look at reliability. There's 3 ways to measure reliability, and the first is called internal consistency. And this is where all items on the scale measure the same attribute. And Cronenbach alpha is the measure of internal consistency. That is, how closely related are a set of items are as a group. So it is considered to be a measure of scale reliability. So I have a couple examples coming up which might make it more clear, but we just want to make sure that all the questions or items on the scale are measuring exactly what we want it to measure. And here, the Cronenbach alpha, we like to see values 0.7 and above. The second major way is called test-retest. So this is really good for stable characteristics such as temperament versus moods and attitudes. And the ranges on a test-retest are from 0 to 1. And the higher the value, the more reliable. So a little tip, reliability coefficients higher than 0.7 are often considered adequate, but coefficients greater than 0.8 are preferable. So you might see it in a research article, R greater than or equal to 0.8. That is how we measure test-retest reliability. And the third one is something we call inter-rater reliability. This is where 2 or more observers or coders, researchers or research assistants who are gathering data using a scale or a tool, make independent observations, and then the degree of agreement is calculated. And so the percent of agreement we like to see is greater than 75%, or Cohen's kappa range from -1 to 1. So once again, values above 0.8 indicate good agreement. So for all three of these, the best way to remember it really is 0.7 is acceptable, but 0.8 is ideal. So let's go through a couple of examples. And this is where I would suggest that you kind of pause and try and work through these on your own, and then you can double check your answers. So the first one is, these are all real studies actually. So the first one is Hawthorne and colleagues in 2011 assessed the stability of scores on the spiritual coping strategies scale. And the test-retest reliability was 0.8 for the English version and 0.84 for the Spanish version. I'm not even sure if I can pronounce it. Abu Kari and co-researchers in 2012 evaluated the Illness Perception Questionnaire, a scale developed for adults of European origin, but it hadn't been evaluated with people from African cultures. So in their study of 221 adults of African descent living in London, the internal consistency, reliability on the scale range was 0.65. And then Cossitz and Jones in 2011 studied interruptions experienced by nurses in an ER, emergency department, and they developed an observational tool form to record nurses' tasks and type of interruption experiences. So probably looking a little bit at productivity here, and the inter-rater reliability was assessed and found to be 0.82 or 82%. So in this situation, with Hawthorne and colleagues, test-retest reliability is good, so we would consider that reliable. In the second situation, the internal consistency was only 0.65, so it doesn't meet our minimum of 0.7. So I would say that would be unreliable. And then the third one, as far as inter-rater reliability, we had 82%, which is acceptable, so we would consider that reliable. So validity, there's three ways to measure validity. Number one is content validity. And what we ask ourselves here is, does the measure contain the entire universe of possible items? So how would we go about determining if a scale to measure happiness contained the entire universe of possible items? Well, sometimes we would do a lit review and look at what's in the literature around, characteristics or what the concept of happiness should involve. Sometimes we'll do a qualitative inquiry. Maybe we'll do interviews or focus groups with people who are happy or not happy, and develop a list of possible items for a tool. So usually based on expert judgment, and should be reported who the experts were. So the researcher might say that content validity was determined by a panel of expert nurses and physicians working in that area, something along those lines. Criterion validity examines the relationship between scores on an instrument and some sort of external criterion or gold standard. So they find a tool that is what would be considered the gold standard with high validity, and then they create their own tool and use both tools and compare and contrast the results. So if they're establishing criterion validity, the researcher should name the other tool it was compared to. And the third type of validity is construct validity. And this is where the researcher provides evidence to establish the tool is measuring what it should be and how well a test measures what it's supposed to. So here, of note, the researcher should describe how this was done. And one of the techniques is a known groups technique. So you take a group of people who you know are stressed and you use your tool to test their stress levels. So you take a group with a known concern, issue, problem, and then you use your tool to test and validate and determine if it's valid. Okay, let's just talk then a little bit about appraising data quality in quantitative studies. And I suggest that you watch the narrated PowerPoint on the appraisal tool following this one. So the questions we ask is, does the report offer evidence of the reliability of the measures? And if reliability is reported, which estimation is used, and is the value sufficiently high? And same with validity, which validity approach was used, and do the report use in a previous study? If there's not reliability and validity reported, then what kind of conclusion can you really make about the quality of the data? And another thing to think about is, was the research hypothesis supported? And if not, maybe data quality or measurement could have played a role. So in research design, what type of design we choose needs to be able to allow you to answer your research question. So some of the things we consider is, will there be an intervention? If we're not testing an intervention, then we can choose a non-experimental approach. Is it possible or ethical to randomize the sample? And often in healthcare, that is one of the issues that causes us to choose a quasi-experimental design over a RCT. Will there be a control group or a comparison group? And what data will be collected and when? And so there's 4 main approaches to data collection. Cross-sectional refers to collection of data at one point in time. Longitudinal is where we have collection of data over an extended period of time. And that typically, it could be a month or, months to years. So for example, there's a big, huge study in Canada called the Canadian Longitudinal Study of Aging, where they actually follow participants for 20 years. And you can become a participant in this study if you're over 55, and you are, they gather data annually through physical assessment, emotional assessment, bone density, a huge range. They draw blood, they ultrasound your carotid arteries, etc. So I'm actually a participant in that study, and it'll go on for 20 years. Prospective is where we gather data looking forward. So the example of both the studies we've looked at so far, the stress in nursing students and the kangaroo mother care, those are both prospective studies. But sometime we do a study retrospectively, and this is only for non-experimental research. So there's something that we are interested in studying, and we look back in time to gather data. So you might have a group of people who develop lung cancer, and you decide you want to go back and retrospectively look at, health and lifestyle practices that might have contributed to that. I was involved in a retrospective study where we wanted to see if home follow-up of premature babies impacted their some short-term outcomes around growth, feeding, ER visits, and hospital readmissions. And so we had a sample from Calgary that was receiving post-discharge follow-up, and a sample in Toronto that was not receiving post-discharge follow-up. So, and then we looked retrospectively backwards at their growth, how many times they went to the ER, how many times they were readmitted, and their feeding practices. So another question is, how did the researcher plan the intervention to control for extraneous variables? That's really, really key. And we know that having a random sample and having really strong inclusion and exclusion criteria can contribute to that, but that becomes more difficult with quasi-experimental design. Okay, we're going to look at the concepts of internal validity. So internal validity basically relates to experimental and quasi-experimental design. So the question is, does what you do cause what you see? So is the independent variable responsible for the effect on the dependent variable? So we're looking inside the study. What happened inside the study, and was the research done right, is another way to think about it. So we're going to look at this little diagram that I created that looks at the key aspects around internal validity. So they really break into three categories: threats to validity related to the participants, threats to validity relating to measurement, and threats to validity related to the researcher. So let's start at the first one, selection or selection bias. And this occurs when your random assignment or random selection was not very random. So one experimental group has characteristics that impact the dependent variable. So maybe you're studying aggressiveness and you end up with 3 MMA ultimate fighters in one of the groups. So even though it was random, the sample ends up not being as random as you'd like. Something that you necessarily can't control. Maturation is when your participant changes. So an example, you are studying white supremacists, and your participants mature during the study and realize their beliefs are not sound, or change their beliefs, for example. History relates to something occurs, or some major event occurs during the experiment that affects participants. So simple example, you're studying opinions on politicians, and a big scandal is discovered during this study. Or you're studying the effects of terrorism and 9/11 occurs, something like that. So something in history occurs that affects your study. I can think of COVID, and maybe you're conducting a certain study on something and COVID hit, and that could affect the results of your study. Mortality relates not to death of the participants, but participants drop out. So part of informed consent is allowing participants to leave the study of their own free will. And so you have to think about how would results differ if everyone remained in the study. So mortality is really loss of your sample size, and that can definitely affect internal validity. And then the last one is contamination. So contamination is when people from the experimental and control group talk and share what's happening in their individual groups, and that could impact treatment. So, for example, in the stress and nursing student article, if students that were experiencing the mindfulness training started talking to the students in the other group about how wonderful it was and all the benefits and you should try it, then that could impact the results. Instrumentation refers to is really a threat to reliability. So this can occur when the instrument or the dependent variable measure changes during the experiment. So say you're using a weigh scale and your scale loses accuracy in a weight loss study or something like that. And then testing effect refers to when, say you're doing a pre-test, post-test, and you're measuring quality of life. So the pre-test measure itself affects the experiment. So just by asking an individual those questions might change their way of thinking and might impact the way they respond differently in the post-test. So another thing is if the participant remembers the pre-test questions, did the treatment really work, or do they just remember their answers? So really key with pre-test, post-test design. And then the last one is researcher threats, experimenter expectancy. So this is where the experimenter behavior can impact causal logic. So the researcher wants it to work, so you somehow influence your participants to make it work. Okay, let's look at the opposite, external validity. And external validity lives outside the study. And the question we ask ourselves is, does the same thing happen in other settings? So the definition of external validity is the ability to generalize the findings to other settings or sample populations. So there are a couple key threats to external validity. Number one is what we call reactive effects or Hawthorne effect. And this was actually discovered decades and decades ago, where they wanted to test the impact of better lighting in sort of like what would in a So they wanted to test the effects of different lighting on productivity in kind of an assembly line type of job. So they had workers that remained with poor lighting, and then they had workers that had improved lighting. And because the workers knew they were being studied, they automatically increased their productivity. In fact, productivity improved in both groups. Likely unrelated to the lighting, just because of the fact they knew they were being studied. And Hawthorne effect is certainly one thing we see even to today. We always have to think about that. Sometimes research projects will mention that in their limitations, that there could have been a Hawthorne effect. So something we just need to be aware of. The other one is selection effects. So your sample is not ideal. So you might have had a randomized sample, but it didn't turn out to be that random. And there might have been some significant differences between your experimental and your control group. Mortality, obviously loss of participants or maturation or change of the participants over time. That's more likely during a longitudinal study. And then there's the notion of the placebo effect. So people think they're getting a headache pill, and so even though they're not, their headaches improve or go away, or there's less severity. And so this is one of the reasons for blinding in research, where we don't want people to necessarily know what particular intervention they're receiving. So there was this interesting experimental study done looking at long versus short hospital stay on the decisions of first-time mothers to breastfeed. And what was interesting is that the length of hospital stay did not affect breastfeeding rates, and all rates were higher than citywide rates had been historically. So this was an example of the Hawthorne effect. These mothers knew they were being studied, and they knew they were being studied around their breastfeeding, and so all of them worked harder and got the resources they need to be able to continue to breastfeed post-hospital discharge. So in this sense, this looks really more like a quasi-experimental design. Okay, let's move on to look at sampling. So with sampling, it's really difficult to observe all cases, and so therefore, as the little diagram shows, we study a sample of the population. So we want to make sure that our sample is representative of the population. And so sometimes that's where sampling bias can occur and can affect the results of our study. So the manner in which the sample is drawn, it really has an impact to determine the extent to which we can generalize from the findings. So sampling inclusion-exclusion criteria, we talked about this last week, and this is where we consider who is included and who is excluded. And inclusion basically defines who is eligible to take part, and exclusion defines who is not eligible to take part. And largely, exclusion criteria is done to control those confounding variables, as we talked about last week, things that could impact your results. So questions to ask ourselves about sampling is, did the researchers use a random process to select and or assign the research participants? And so we call that random sampling, but often you might hear the term random allocation. So this is where we draw a sample from the population, and then we randomize that population, we allocate them to the experimental or the control group. So example of this, there was an interesting study done on premature infants less than 32 weeks. And so they obviously took a sample of premature infants, and then they randomized them to receive the intervention and a group to receive the standard of care in the control group. So they were testing a brand new intervention, so adhering to justice, making sure the control group received the minimum standard of care. So that is sometimes referred to as a random allocation. And then there is convenience sampling, which is non-probability sampling. And this is where you you access a population that is convenient and easy to access. So questions to ask: are the accessible population and the sample drawn representative of the target population? So we have all different kinds of approaches to try and achieve that. The other thing we need to ask ourselves is, did the researchers consider sample size? Is it sufficient? And did they do a sample size calculation? Did they enroll and maintain a minimum number of participants? Or did they suffer from mortality and loss of sample size? So we're going to look at 4 types of random sampling, and the first one is simple random. It's often referred to as a lottery. So say I was conducting a study in this class of Health 2250. I took the class list, I cut it up into individual names, I put them all in a hat, and I chose the 10 students that I wanted to have in my sample. The second one is systematic random. So this is where we take the broader population, and we might choose every 3rd or 4th or every fifth participant in the population to make up our sample. So an example of this is if I took my class list and I decided to choose every 3rd student to be involved in my study. Stratified random is really a type of sometimes referred to as quota sampling. So this is where if we know something that we feel could affect the results of our study, we take the broader population and then we divide it into stratas so that we can be assured we have adequate representation of those different stratas. So the little picture you can see, we have the whole list of clients. We feel that ethnicity could impact this particular intervention we're testing, and so we divide them into Caucasian, African American, and Hispanic, and then we randomize from each of those groups into the control group and the intervention group. Cluster is really several stages of random selection, and this is often used in marketing research. So they did a study in Calgary called What Makes Calgarians Cranky, and they started by approaching this by several stages of random selection. So they're looking at the entire city of Calgary and they randomly select different communities. Then within those communities, they randomly selected different streets, and then within those streets, they randomly selected odd house numbers, even house numbers. A lot of times people would arrive at your door to do sort of telemarketing research in the past. Now they call you. One of the main reasons I don't have a home phone anymore. But a lot of marketing research is done through the several stages of random selection. Don't see that as much in healthcare. So let's look at 3 different examples of sampling methods and see how you do. So I'd have you read the scenario and try and identify the sampling method. So the first one is, this was actually a study done at Mount Royal. A psychology instructor wished to study the effects of providing a 1-hour check-in or 1-hour office time with students to determine if that impacted student success on their final paper. And she utilizes the class she is currently teaching. She uses a lottery system to select half of the class to receive the 1 hour of office time. She then compares the grades of the students who did and did not receive the office time. So obviously that's an example of simple random. So with this situation, your college or university wants to conduct a survey of student attitudes and opinions on the quality of student life on campus. So using a list of all registered undergraduate students from the registrar's office, the administrators want to select randomly from that list 100 first year, 100 second, 100 third, and 100 fourth year students to make up their sample. So here they're feeling that the year that students are in of the program of their university experience might impact their attitude or opinion on the quality of student life on campus. And so this is an example of stratified random. All right, let's look at design as far as data collection. So we've talked a lot about reliability and validity of different tools that might be used to collect data. So we always want to ask ourselves, how was the data collected and what are the advantages and disadvantages of the selected method in terms of the possible impact on the research findings. So we use instruments or tools, and it could be biophysiologic data, as in very common in healthcare, heart rate, rest rate, urine samples, blood samples, MRIs, etc., physical testing, versus abstract concepts like we talked about: depression, stress, anxiety, hopelessness, happiness. And then with non-experimental research, there is this notion of the survey and this notion of self-report. So usually in the limitations section, researchers will identify that sometimes self-report can be an issue because you never know if people are truly telling the truth or how they interpreted the question. There's also something called social desirability bias, where people might say something because they know that's the socially desirable answer to it. So we might use questionnaires, delivery method, we might mail out surveys, but more commonly now we're doing online surveys. And so sometimes there might be a consent, a digital consent you have to check some boxes on or sign, but sometimes researchers assume if you go on to complete the survey, it's implied consent. Sometimes we do interviews, and that could be face-to-face, or it could be via telephone. And the one thing we always need to consider here is this notion of the Hawthorne effect, because we do collect data through observation as well. And we'll look at that in some upcoming studies. Just getting down to our last couple of slides here on data analysis. I've alluded to this in the quantitative appraisal worksheet, the things that we need to look for, but with non-experimental research, we're typically looking at descriptive statistics, whereas with RCTs and quasis, we're looking more for correlation or, indeed that the independent variable impacted the dependent variable. And so typically here we're using inferential statistics, so tests to measure relationships and differences between variables. So just the last slide on a learning check. Practice differentiating between experimental, quasi-experimental, and non-experimental designs. Identify each of these in research designed in published literature, and get used to practicing differentiating between the four basic research designs: retrospective, prospective, cross-sectional, and longitudinal. And I just bring back this little flow chart from the Nurse Killam video, and the study we're going to be looking at in our synchronous time together is the kangaroo mother care quasi design. And so we ask ourselves, was there an intervention? Yes. Was there a control group? Yes. Was the sample random? No. So it falls into the quasi-experimental design. Thank you for listening.